Welcome, everyone. I just want to say how great it is for everyone to be here today. This is our EMD weekly seminar, but today it's a special occasion because we are co-sponsoring this event with the Yale Institute for Global Health and the EMD department. Thank you to all of our EMD students who are here, and a special thank you to all of the people who came from all over campus to participate in today's session. So I've asked our colleague Greg Gonsalves to introduce our speaker today.
Hi, everybody. So I was trying to figure it out, but I think I've known Joia for almost a quarter of a century, which is sort of weird. And the first time I met her was at our lunchtime presentation at the Yale Club of New York surrounding the UN Special Assembly on HIV/AIDS. And Joia had to give this lunchtime presentation, clattering of plates, and she's like, "Don't worry, I've dealt with more rowdy crowds than singing in bars throughout Cambridge and Boston." So that story is etched in my mind 25 years later. But Joia does something more that makes her a very special visitor to this place. She has her qualifications as medical director of the Department of Health, so she's professor at the Brigham and Women's Hospital and Harvard Medical School. But she's been a voice of and a beacon of moral clarity in global health for as long as I've known her. Whether it's when we fought for access to antiretroviral therapy when everybody said don't do it, or when we fought for access to NDR-TB treatment when everybody said don't do it. Joi's been focused on what is right and true for all of her career, and it's a really special treat to have her here at Yale to talk about the future of global health. So everybody give a great.
Thank you, Greg. That's just so kind of you. Thanks for having me. I'm really, really happy to be here, and it was a super nice train ride. I have friends here, new and old friends, and I was trying to think the last time I was here, but I think it was with Dr. Friedland talking about TB. It was a long time ago, and I'm glad to be back. So one of the things I know that is on all of your minds is, what is the future of global health? And I don't have an answer for that. But what I do have is kind of a bit of a history that we can talk about together. And please feel free to chime in, raise your hand. I'm very open to that. And a bit about where we came from and how we might look forward in the future and what kinds of things we might want to do. You have to be optimistic to be in this work because, as Greg said, 25 years ago, 30 years ago, there was no treatment anywhere for almost anything in places like sub-Saharan African village or a small hamlet in the Andes in Latin America. So we've come so far, and I think it's on us and you and the next generation to figure out how we continue to build on what we've, succeeded at building and doing. So I have no disclosures. Nobody would support me. So we were at a point in the road many years ago when Greg and I met, when I met Dr. Friedland, when others, where the point in the road was not great. There were very many sick people around the globe, and most of them got no treatment for anything. But the question was, so how do you change that, right? How do you navigate that fork in the road? And the key thing is to know where you're going, right? Where are you going? Because anything can be okay. I mean, as I'll go over, there was very little treatment for any diseases. So you could say, well, if we treat malaria, that'll be good. But that's not where we're going, right? We're not going toward malaria treatment. We're going toward justice. We're going toward human dignity. We're going toward healthcare as a human right. And those are not single issues, right? They're issues that contain multitudes of needs and ideas. So I always think about this quote from Lewis Carroll when Alice gets to the Cheshire Cat and, she says, "What road do I take?" And he says, where are you going? She says, I don't know. And he said, well, then any road will take you there, right? So we have to know where we're going, and I think that's where we are at this moment, and I'll get to that at the end, because that's where we need to bring our heads together, collaborate, and think about, okay, we know where we're going, what are the next steps we need to take? So you guys have seen this, right? What is this? What is this? It's cholera. Is it cholera? No, it's not. It is cholera. It's a map, right? Who made this map? John Snow. Thank you. Okay, you all get an A in your, Public Health 101 class, right? This is the map that John Snow made. And what's in the circle? The Broad Street Pump, right? It's so famous that when you go to Broad Street in London, there's a bunch of public health nerds like us who are taking their pictures there, right? Really, right? So what made this pump? What made this map? What made John Snow so famous? He took the handle off, which is like in a Bob Dylan song, speaking of singing folk music, right? The pump don't work because the Vandals took the handles. So he took the handle off, right? So why? What was he thinking? What was he doing? And why do we sort of hold John Snow up as an icon of our discipline? Yeah.
Well, the real controversy was that at the time people thought that cholera was airborne.
Okay.
And nobody believed him that it was transmitted through water.
Wonderful.
And then he mapped through shoe leather epidemiology.
Yeah, we love that. So he says, wow, there's a bunch of cases here, there's a bunch of cases here, and they really seem to be focused around this pump. So his intervention is to take the water off the pump. Was that a good idea? Yeah, we're all nodding yes. I don't know. If you're a mom who has 6 children in 1800s in London, and some dude who definitely was wearing a bow tie, right? Any bow tie wearers here? No? Okay. Some dude definitely wearing a bow tie, erudite, comes and dismantles your water pump, what would you think?
Get out of here.
Get out of here, right? That's my water pump, right? So what does that mean for a woman? Women and children around the world are the ones who fetch water, right? We know that. And at great difficulty, really. We know from Darfur, for example, that fetching water and firewood are independent risk factors for rape, right? We know that fetching water and firewood can make kids drop out of school, right? So in the 1800s, London is no different. So what do you think a mom is going to have to do who has 6 children now that Jon Snow and his bow tie have come and take the handle off the pump? What is she going to do? Because she needs water.
They walked to a different pump.
So she's going to have to go over here, maybe Golden Square, right? And what do you think is going to be her experience at Golden Square? Why do you think Golden Square pump doesn't have cholera? What do you think? Think that, well, maybe let's just say for ease, maybe it's 30 minutes. So she's going to take 30 minutes there, wait in a long line because everybody else from her neighborhood is going to go to Golden Square too. Wait for an hour, 2 hours, fill up her bucket, come back. How is that experience for her? It's time consuming, right? It's getting out of her safety zone because she's probably a poor woman in tatters and have to go to some fancy neighborhood to get clean water. People are going to spit on her. They're going to disrespect her, right? So I like Jon Snow, right? I like bow ties. But I think that we make a mistake if we think that a simple public health intervention is the solution for a large-scale social problem, right? So the cholera in the water in Broad Street is a social problem, right? It has many layers. What do you think is happening? Let me see if I have my next slide. No, I don't. What do you think is happening there? There's a beautiful cartoon from 1850 called Court of King Cholera. And it's a picture of the people living around the Broad Street pump. That was before Jon Snow took the handle off, right? What do you imagine that to look like? The area around this pump. Do you think it looks the same as Golden Square? No. What do you think? What would be, things you might see if you're observing, right? Because as public health people, we're also observing our environment. What would you be observing in that area? Poverty, right? Probably lack of sanitation, lack of trash pickup, maybe people without housing, living in congregated settings, right? Maybe a prison, maybe a flop house, right? That is how we know what these things are about. So if you take the handle off, you're not addressing the root cause, right? So nothing really wrong with doing that prevention, but I think we have overestimated the impact of a preventive, intervention when you have a large-scale social problem like impoverishment, like discrimination, right? So the reason I spent a little time talking about Jon Snow is that is what I call global health 1.0. It's the global health a lot of us grew up in, where we said the only thing we can do is prevention. When Greg was talking about when we met, people were saying you can't treat HIV. It's too expensive. Just prevent it. So how do you prevent HIV? How do you prevent HIV? Anybody know? What's the best method we have of preventing HIV? Right now, it's clear. Treatment! Right? Treatment, PrEP, which is a kind of treatment. It's a drug-related, yeah? But we were told, no, treatment is too expensive. Just do prevention. People didn't really appreciate, nor did they want to appreciate that treatment was prevention, although it is in many infectious diseases, by the way. But it was tell people to abstain from sex, be faithful to your partner, or wear a condom. A, B, C. That's what we grew up with. Greg, myself. We do ABC. Do ABC. So how does that work? I have news for you, okay? All of you, abstinence. Your parents, not one of your parents abstained from sex, right? Difficult as that may be to accept, we are all the product of a lack of abstinence, right? It is human nature to have sex, right? And that is part of our being as human beings, right? So the idea that people would abstain is kind of a joke, right? It's good for certain people to abstain if they're young people, but it's not a tenable strategy for an entire population, for people of all ages, for people of all persuasions, right? It's just not realistic, right? The second, be faithful. How does that work? Does that work? Being faithful? Okay. One of my very first medical students I worked with when I became faculty at Harvard, a woman named Molly McNary, who's going to WashU in St. Louis to be the chair. She and I did a study in India looking at risk factors among women who had HIV in Rajasthan. Among the women that had HIV, they were more likely to be married. So why is that? Do you think they weren't faithful? Yes, right? So when you say be faithful, who are you talking to? Right? Are you talking to a young woman? Are you talking to a man? So these are very kind of idealistic things that in real life have super big challenges. And then similarly with wearing condoms, condoms are very much male controlled. Condoms are, have lots of challenges. So I've given out thousands and thousands and thousands, probably millions of condoms in my life. But we know that once people are in a relationship where they trust one another, condom use goes down. So, and then you have to rely on the other person being faithful. So these strategies were limited, yet scholars wrote papers saying prevention is 28 times more effective than treatment. How would you even make that argument? How do you even measure? Modeling, you can do this, that, but this was like a data-free zone, frankly, because we didn't know what population level treatment would look like. We certainly had no way to measure the efficacy of ABC. There's no way to measure that, right? So it was a bogus claim, what my dear departed friend Paul Farmer would call an immodest claim. Immodest claim, like we're arrogant thinking that we can make that claim, that our preventive measures are preventing 28 times more HIV than treatment. And we know it's not to be true. So in Global Health 1.0, we were told, keep it simple, KISS strategy, keep it simple, stupid, focus on prevention, and treatment is too expensive for you. Are there any Africans in the audience? From Anglophone Africa, a few of you. Okay, so you are going to help me do something that most Americans have never heard, right? I am your school teacher. I say prevention is what? And you say? Better than cure. Well, maybe your schools were more progressive. You never heard that?
No.
You get it? No, they are like that. But once you come to the United States, you forget that because it's such a dumb thing, right? But throughout Africa, right, teachers are standing in front of young children saying prevention is what? And they say better than cure. Does that happen in American schools? No. If I said prevention is what to my kids, I mean, they would have no idea. Not at Brookline High School. Right? Not here in New Haven. So why do you think young children are saying this over and over again like dogma? Is it cultural? Where does that come from? Prevention is better than cure. Money. Just about money. You're not going to get cured, so you better not expect it. And if you get sick, it's your fault, by the way. Because you didn't prevent, right? So we indoctrinated an entire generation of people, but also providers in the global north as well, that prevention is the only thing for you. This has a very clear history, okay? Global health, and this is where we are now. I'll get back to that. Global Health 1.0 came from a specific era, really, because in the liberation struggles on the African continent, in a lot of the liberation movements in Latin America, there was the idea that everyone should have health care. There was the building of universities and medical schools and nursing schools. But that took a backseat to the politics of the Cold War. The politics of the Cold War were really to, on the US side, make sure that governments in Africa and Latin America were not super powerful, that the private sector was more powerful. We took money out of government programs through a variety of means, the most important of which was the World Bank and the IMF. The World Bank and the IMF said, we'll give you money, but you have to slash your public budgets. So slash your public budgets in favor of privatization. Charge user fees for health. Charge user fees for education. Buy American goods, right? Privatize your water. That's what governments had to do to get loans from the World Bank and the IMF, right? And in that slashed public sector budget, which for most countries in sub-Saharan Africa was about $5 per person per year in the 70s, in the 80s, in the 90s, $5 per person per year, there's not a lot you can do besides prevention. So interestingly, it neatly fit together with the idea that prevention's better than cure, because you can't afford cure, so you better be okay with that. So meanwhile, Africa is the richest continent, but countries did not have control, and they still don't in most countries, Botswana being an exception. The resources of impoverished countries were constrained by these structures. So you have no public health budget. Your budget is maybe $5 per capita. And everyone's telling you prevention's the only thing that works for you, right? And these terms seep into public health, like sustainability. I cannot tell you how many times in the 30 years I've been doing this work, 35, 40 years, that people say, oh, but Joia, that's not sustainable. Treating HIV, treating cancer. It's not sustainable. What does that mean? What do you think that means it's not sustainable? What it means is it's not sustainable on the resources of the country X that you're working in. But who created that health budget for country X that you're working in? These systems of extraction, of colonialism, and structural adjustment make it so governments have no money, and then we say, oh, you can't do that because that's higher than your health budget. We created that, right? So these terms, sustainability, appropriate technology, for years, the late, friend, Richard Cash, and I would have a debate at the School of Public Health about whether or not, even into the modern era, whether or not we should treat HIV. He said, it's just not appropriate technology. Viral load is not appropriate technology. It's like, appropriate for whom? Right? He showed one time in a slide, he did a lot of work on cholera in Bangladesh, and one of these cholera beds with a hole where your butt needs to be. And he said, see, this is appropriate technology. I said, that's highly undignified. I'm sorry. If I had cholera, if my mom has cholera, I do not want a hole in the bed by her butt and a bucket. I'm sorry. It's not okay. But that's appropriate because we don't have nurses, because we don't have clean sheets, because we don't have laundry. Well, you know what? Not okay. Right? That means we will have a direly poor standard of care for people. So who gets to decide what technology is appropriate, what is sustainable? If it's the resources constraints that we've created, that's the problem. So we had two opposing views in the Cold War. One was the view espoused at Alma Ata, which interestingly and importantly was held in the Soviet Union, right? So health and public health is political. Don't ever think that it's neutral. It's not neutral. Right? So in the Alma Ata, the promise was healthcare for all by the year 2000. But that wasn't the only promise. Interestingly, and something we often forget, was that within the Declaration of Alma Ata, there was an idea of multilateralism. That in fact, we can't say to country X, you stand on your own $5. But affluent countries would do well to increase substantially transfer of funds. This is in 1978. This is a radical idea, right? That never happened because within a year of the publication of the Declaration of Alma Ata, we have this very famous article, a special article, right, on selective primary health care. And notice the subtitle is an interim strategy for disease control in developing countries. Now, does it come from a developing country? It does not. It comes from Julia Walsh and Ken Warren at Johns Hopkins Hospital. The Declaration of Alma Ata was published in the British Medical Journal. The selective primary healthcare article was published in the New England Journal of Medicine. Again, these are political decisions, right? The US, which is promoting the $5 structural adjustment spending caps versus the UK that has the NHS, right? A public provision of healthcare. So when we look at articles, yes, you want to look at who funded it, but you also want to understand the political economy of who's saying what and why. right? So they said, these are the things we can probably do, right? What we can't do community water. So we're back to Jon Snow, and this is why Jon Snow becomes a hero. We can't possibly do community water. That's $30 to $54 per person. We can do mosquito control. We can do some deworming. We can do selective primary health care. And selective primary health care was a particular thing, right? And that selective primary health care, I don't know if I have a slide of this. Yes, was something that many of us have done. Don't do this, right? I'm trying to protect you from your, a life in one of Dante's rings of the Inferno. Okay, don't do this. I did it. I would like not to see you in the ring with me. Okay, this is something called GOBI, growth monitoring, oral rehydration, promotion of breastfeeding, and infant vaccination or immunization. Right? GOBI is selective primary health care. So what do you do in GOBI? You put this baby in this bucket. It's usually blue. Just, and it's a gaffing hook for those of you who are fishermen. You don't really gaff the baby, but So you put the baby, and somebody is giving education, and they have a card called The Road to Health. And it's published in every language, so it's appropriate technology, right? Because you can read it in Haitian Creole, you can read it in Swahili, and then you put that baby, you weigh that baby, you put them on the card. Where are they, right? Are they growing appropriately? That's growth monitoring. That's the G. You educate the moms about how to make oral rehydration salts, right? That's the O, right? You tell breast is best. Exclusive breastfeeding till 6 months, continue breastfeeding to 2 years, education campaigns, and then you do vaccinations for the kids. GOBI was pretty much all there was the first time I ever started working in Africa, which was 1991. I did GOBI. I did it just very much like this, under a tree. Everyone's like, oh, it's so sweet. It's under a tree. It's not sweet. Why should people get health care under a tree? I don't get my health care under a tree, right? Women would be standing in line, often they're pregnant and holding a baby in the arms. If that mom is hungry, if that mom is coughing or has a limp or a broken leg, nothing to do for them. If a child has pneumonia, nothing to do for them. But you're going to diligently put that kid's weight on the chart. And when the weight is going down and down and down, what do you think you do in GOBI world? What do you do? Nothing. You educate the mom. You take out your poster, and it has 4 food groups. And you say, Mom, your baby is hungry. They have malnutrition, okay? You see this, these are the 4 food groups. Here's leafy green vegetables, grains, protein, could be a chicken leg, could be an egg. Your kid needs more of that, okay? Okay, come back and see me in 3 weeks, and we'll weigh little Johnny again. That's growth monitoring. I did that. That's all we had. And GOBI was so popular. And by the way, it kind of worked for some kids because infant vaccination is a fantastic way to save lives, because oral rehydration is a fantastic way to save life. So these are preventive strategies that have some impact. It's not like prevention is bad, but there is no treatment even for something like malnutrition within that plan. But it was so popular, read cheap, that they even made like a stamp. This is a stamp of GOBI from Nepal. They love GOBI. We love GOBI, right? So that's Global Health 1.0. Prevent, don't worry about treatment, do it under the tree. All these people basically are volunteers. They don't get a salary. They do this work out of all the posters probably come from the US government because we like education. We think these people are dumb anyway, so like, let's just educate them, right? That's Global Health 1.0. It had some successes, especially improvement in life expectancy for children under 5. No successes on adult mortality, no successes on neonatal mortality, no successes on maternal mortality, but kids did better, a little bit. So then what happened? This is kind of that, how we got to Gobi. But at this time, 1 year of HIV medicine, $10,000 per patient per year, right? Standard TB therapy, not even drug-resistant TB, 55. So there's no treatment for HIV. There's no treatment for TB. There's certainly no treatment for hypertension, cancer, acute respiratory infection, God forbid, road traffic accidents that need surgery, all of the mental illness, nothing, right? Nothing. But then this little gain we had from Gobi starts to go away. 94, 95, 96, 97. We start seeing these gains that we are public health people, keep it simple, stupid, prevention is better than cure. We think this is great. Look at how good we're doing. That starts to fall. We see declining life expectancy for children even, and suddenly declining life expectancy for adults. What caused that in the 90s? What caused us to kind of scratch our head and say, maybe Gobi is not enough? Then people put in like family planning, ferrous sulfate, female education as an idea. Gobi, FFF, they tried to make it better. What do you think is happening? Why were we losing ground in the 90s despite our best Gobi? Yeah, HIV. HIV epidemic starts to take off in places like Uganda, right? In East Africa, then Southern Africa, right? 30% of women who are pregnant have the illness, right? And children start dying. Why do you think children were dying? Why do you think children were dying in those dark, dark days of the HIV pandemic? What?
Their moms were dying.
Their moms were dying, right? So yes, some of the kids had HIV, but we had what was called the orphan crisis. How are we going to address the orphan crisis? And then in 1995 and 1996, we have the discovery of the cocktail that Greg Gonsalves and others really had fought for. Expansion of science, rapid development of new drugs, clinical trials. And we saw that this disease that once was a death sentence became a manageable illness. Lifetime, do well, go back to school, get your PhD. One of the very last patients I saw when I was an ID fellow was very, very sick on a ventilator, and he was there with his partner, and we were trying to decide, do we stop therapy? He was, stop even the ventilation because he was so sick. And he said, we're enrolled in a clinical trial. Has this new drug called Indinavir. And I think if we can get him better and get him home, maybe there's some hope. So he went home in a wheelchair with a tracheostomy, thin as a rail. And because I was a fellow, I moved on, and I lost touch with that couple and that patient. And about 4 years later, I get this beautiful embossed invitation to his law school graduation. Still gives me chills. Like, I actually just got chills, right? This is someone who was so close to death. And I had been working in Africa. And I see so many of my friends, school teachers, nurses, doctors, pastors, that were dying of HIV. And I thought, oh my God, this is amazing. we have this treatment. Let's go and give it to people who are 95% of the pandemic. And in these years, right, we had the HIV treatment, the cocktail, 95, 96, 97, 98, 99, 2000, 2001, 2002. And in those 8 years, 8,000 people died a day in sub-Saharan Africa, a day, without therapy. Without anyone thinking that this was for the majority of the pandemic. You have 26 million people on the planet with HIV. 95% of them live in sub-Saharan Africa. And 8,000 of those are dying a day because we want to hang on to the patents. We want to hang on to the world order that says prevention is better than cure. There will be no cure or treatment for you, right? I'm going to skip this for a second. I'll go back. So, what changed? There was this massive movement led by amazing people, some of whom are in this room, right? To say that, you know what? That's not right. That's not justice. My life was saved by these treatments. Some mom in Soweto has just the same right as I do. A commercial sex worker in Bangkok has just the same right as I do. A child in rural Uganda has just the same right as I do. And everyone said this was crazy. Now, I was at that time at Partners in Health. And the reason I signed up to work there is I had been in Africa. I had seen people dying. And I was desperate to just put pills in people's mouths to help people get this fruits of science, which, by the way, is a basic human right. And there was only one organization that was actually doing that, and that was this tiny little organization, quirky thing in Haiti called Partners in Health. I said, I'll work for you guys for free. They said, sure. And that was Partners in Health, founded by Paul Farmer, Jim Kim, Ophelia Dahl. And I went and worked with my Haitian colleagues, my best friend to this day, Dr. Fernay Leon, and we started treating people with HIV using unexpired drugs that were donated to us, mostly by gay men living in Cambridge, Massachusetts, whose regimens were changing. So we had those drugs. We could treat a limited number of people. People said, this is not sustainable. This is not appropriate technology for Haiti, right? The head of the U.S. Agency of International Development said, Africans can't tell time. We have it on tape. They've never seen a watch in their life. My African friends just love to show me to this day. Yeah, there you go, right? Where are you from?
Uganda.
Uganda, right? You know how to tell time?
Yes, I do.
Yes! The craziness, the racism, the capitalism, the protection of patents allowed 8,000 people to die every single day, right? So we started treating these handful of patients in Haiti, and they did well. Not surprisingly. And people said, oh, you didn't randomize it. Randomize to what? Randomize to dying? They said, you didn't randomize. That was one, you know. You didn't have viral load. We didn't have viral load. We didn't have CD4 count. Our main criteria for starting someone on HIV therapy was a positive test, which, by the way, back then was not simple. It was an ELISA. And that they were CIOS, carried in on stretcher. If they were carried in on a stretcher, we gave them ART. If they were not carried in on a stretcher, we'd figure out if there was something we could do to ration the drugs, right? So we treated a lot of TB, gave a lot of food supplements, did other things. But the sickest people, and they're saying, why are you using it on the sickest people? That's not sustainable. They're going to die anyway. But of course, the sickest people are the ones who stand to gain the most, right? All our patients did great. Many of them are still alive, by the way, that we started in 1998. You know, one of our guys was at a HIV conference recently. He's still on Entecavir, right? Which is kind of crazy, but he doesn't want to switch. So our little experiment became part of this global movement, and that's how Greg and I met. right? Because people living with HIV were in a way desperate to say, yeah, it can work over here. And they'd say, look at Haiti, right? And the, academics and a lot of other people, oh, that's silly, it's not sustainable, it's gold-plated, it's not randomized, blah, blah, blah. We said, yeah, but here's our patient and they look really good, right? But that movement changed everything in our field. It moved us from Gobi to something. And that something was pretty magnificent. So this is, so we started treating people in Haiti. That data of our 50 patients, then 150 patients, became used by Jeffrey Sachs, the economist. He came to Haiti and he costed it out. How much does it cost to, give people these drugs? Not at the cost of the drugs, like the nursing time, the X-rays, the laboratory monitoring, etc. And then, took that at scale. He took that costing exercise to Kofi Annan, and that was used to create the Global Fund to fight AIDS, TB, and malaria. Because at UNGA, where Greg and I met, African leaders and civil society partners, people living with AIDS, and the governments who really wanted, in some cases, to take care of them. So we cannot do this on the usual way. We can't just take out more loans. We can't have these $5 per capita budgets. This is what our health system looks like. This is an actual hospital that's open in Rwanda, right? This is in 2005. This is the cupboard. This is a district hospital for 500,000 people, right? This is a ward. Anyone who thinks that's healthcare, it really needs to have their head examined, right? So what people said when we won this money, and then the president's emergency plan for AIDS relief, PEPFAR, which came from George W. Bush, very bipartisan. Senator Bill Frist, along with Democratic senators, Dick Durbin, they're friends. They reached across the aisle and say, we have to do something about this. But it wasn't just about HIV, right? It wasn't just about HIV. It was about the unaddressed burden of disease in general, right? This is a clinic that we started to work in. So when at Partners in Health, when we got money from the Global Fund, the first time, right, 2003, we said this is not about HIV for us. This is about just treating people who are sick, right? Because people don't come to you because they have HIV. It never was for us about HIV. We were not an organization that was founded on taking care of people with HIV. We were founded on making a preferential option for the poor in health care. That means providing care to the people who are the poorest. People who are the poorest have everything. They have cancer, by the way, right? They have HIV, they have tuberculosis, they have mental illness, they have everything. They have a broken leg, kid falls out of a tree, picking mangoes. Like the burden of disease is there. So we said, we have this money for HIV. And this money was really supposed to be just for HIV. But I'm working in this clinic in Las Caubas. The seroprevalence of HIV is 5%. TB incidence is 250 per 100,000. Want to take a guess how many people were found with TB when we first went to this clinic? We'd think there'd be at least 137 cases. There were 9. And people would say, oh, no one's coming because TB has stigma. Do you think that's why no one's coming? Do you think that's why no diagnoses are made of tuberculosis? Because that's what they said for TB. They said that for HIV. Oh, stigma. No one's going to come forward because of stigma. If the clinic looks like that, would you go there? No, right? These clinics are basically moribund, right? They have no staff. They have no stuff. The structures are dilapidated and falling down. People go and there's no one to attend to them. And by the way, it costs money. For this, you're going to pay a user fee. right? And if you're a poor person, you don't have the luxury of taking a day off from your farming or you're running a little business. So you're going to walk, 5 hours for this? No. So we said with the HIV money, our case finding strategy is going to be primary health care. That we will open these clinics to provide primary health care. And then if people need an HIV test, we'll do that. So how did we do that? We walked to the forest reaches of the village. We hired and trained an army of community health workers, but not to provide care, to look for people who were vulnerable, to try to support their neighbors, and to say, by the way, we have clinics and now they're open and there's someone to attend to you and there will be medicine, right? And by building this community health, we did 4 things. 1, we put essential drugs in the clinic. 2, we paid the staff, many of whom hadn't been paid for 9 months, right? I met one of the doctors assigned to one of our rural clinics in Haiti one day in a market, and he was selling radios. I said, what are you doing? You're selling radios over here. You're supposed to be in this clinic. He said, well, I've got 3 kids. What did he mean? He meant he had to pay school fees for his 3 kids, and he hadn't been paid for 9 months. I said, well, how about we do better than whatever you're making with the radios over here? And he's like, great. It's not that people didn't want to work. They weren't getting paid. Pay the staff, drugs, hire and train an army of community health workers, and then try as much as we could to get rid of the financial barriers to care, user fees, transportation, things like that. And in no time, these clinics went from seeing 5 patients a day to 300 patients a day. And when you see 300 patients a day, first of all, your staff is mad because they're super busy. You have to hire more staff. You have to, But what you see then is not HIV. You see everything, right? And people don't come because they want to find out if they have HIV. They come because they're coughing. They come because they're losing weight. They come because they have a broken leg. And then you can offer, I'd also like to test you for HIV. And we were criticized for that too. That's not proper consent. You don't have to get consent. You need a syphilis test to get married, right? And still, right? But somehow the consent around HIV historically, because HIV was this terminal illness, this huge thing built up around consent. And yet these are people coming to you for care. So we'd say, I'm going to do this test. And then if they're positive, then the counseling happens, and it happens for life. It's not like tell you all about the HIV. So we started what was called provider-initiated testing. And that was very controversial, by the way. People wanted to have freestanding clinic, go over there, get your HIV test. That promoted stigma. And it put the onus on the sick person to know they might or might not have HIV, instead of the onus on the medical professionals to think through the diagnosis. Just as many people who got an HIV test also had a test for TB. Just as many people who had an HIV test also had their blood grouping if they were pregnant, right? These were a battery of things that provide good care for people, right? So in this way, we were able to find and treat a lot of people with HIV. And this young man became a very good friend of mine. His name is Joseph June. He was carried into our clinic in Las Cabas, the one you saw that had 9 patients diagnosed the year before with TB. She carried him in her arms. We started him on, so he was carried in by mother, CIOM, right? And we started him on HIV therapy. And in just 6 months, he looked like that. Doesn't even look like the same dude. Same dude. Now, he died recently, of complications of actually tuberculosis, chronic lung disease. But he had a very wonderful 20 years. He got to see all his kids graduate. I'm very sad he died. He was a friend. He was a colleague. But think of his life. But the weirdest part of Joseph June is he became the everyman for HIV in Africa. And he knew it. He was an AIDS activist. He went to many international AIDS conferences as part of our team at Partners in Health. The reason he became the everyman is that Jim Kim, one of our co-founders, went to the WHO. He started the 3x5 initiative at the WHO, and he used this picture as a way, with the permission of Joseph Jun, as a way to motivate people. This picture was up in every HIV clinic in Africa. And we one time were presenting a poster. Actually, he was not there. He was at the conference, but he wasn't standing by the poster. One of my colleagues was presenting and had this picture. And a guy said, "That dude is Kenyan. I know him." I said, no, he's our guy. Somebody said, no, he's from Cameroon. We have that guy. And then here comes Joseph June walking by. Hi, he's Haitian. I've met HIV patients all over the world, particularly in those eras, that said, I want to meet that guy. He became kind of a celebrity, right? But what we did with this activism was we built systems, right? And we did it through different means, right? First of all, we critiqued Global Health 1.0. We said, there's a lot of disease out there and we really should treat it. And it's not about choices, it's about poverty, right? And it's about these situations that people can't escape. So one of our books, Dying for Growth, which is a Partners in Health published book, edited by Jim Kim, was critiquing the World Bank and the IMF and the impact of this $5 per capita on health. One book by Paul Farmer, Uses of Haiti, which showed the international, particularly American intervention in Haiti, impoverished the Haitian government and the Haitian people's ability to make choices for themselves. We had to show that drug-resistant TB impacted every country on the planet, right? And we had to debunk these ideas around HIV that it couldn't be treated. But many other things. We also have our academic arm at Harvard Medical School. We publish papers like, look, we can treat drug-resistant TB in Peru, or we can treat HIV. We can do these things. So we had different arms of advocacy from the NGO level, from the academic level, and then most importantly, working with activists. This is a very famous picture of the Durban HIV conference in 2001, where activists so brave, facing stigma and hatred, stood together and said, you cannot have this conference in our country until we can get this antiretroviral therapy. So brave, amazing people. Many of them are still alive because of that fight, right? So Global Health 2.0 really was marked by activism, particularly the movement for HIV treatment, access. It's marked by internationalism, a heady time where people thought, maybe we are in this together, right? Marked by a belief in science. People saying, look, we can look at this data and we can see that this will happen. And, we benefited from a globally very strong economy. Creating PEPFAR, the Global Fund. This is one of our friends who took this picture, one of our friends, Aki Ahmed. But you see the increase in money that came through this activism. And that increase in money was used predominantly for what's now called health system strengthening. There are very few vertical HIV programs anymore. They are part and parcel of a health system, whether at primary care level, community-based level, or hospital level. We started this 3x5 thing, which I'll skip over. And many of us, I think, Greg, you might have been on these antiretroviral guidelines that we made at the WHO in 2001. They're redone every couple of years. And that gives countries the support and the roadmap to treat HIV in their own countries. Right? So what happened when we won that fight for global AIDS treatment access, it was like the dog catching the car, like we thought, we're going to get this money, and then we got it, right? And then what do you do? So that's where the building of health systems came in. And this is just some pictures about some of our first public clinics that I was telling you about. We published this in the Journal of HIV, J-AIDS, but just showing that doing these basic things could both improve access to primary health care and find and treat all of our HIV. In these communities in rural Haiti, within 5 or 6 years, we had found every single person with HIV, and they were all on therapy. Right? So we had achieved universal coverage of HIV. But we also documented that we had improvements in childhood vaccination, improvements in TB case finding, right? That the whole health system could get stronger. And we really promoted the idea that these systems were linked, community-based systems, health centers, right? And tried to cost out this model of care. So Partners in Health, we talk about the 5 S's: staff, stuff, space, systems, and the provision of social support for the most vulnerable as a way to rebuild health systems. This is what happened when we were invited to Rwanda, working with a government that had very, very goodwill to do this integrated model. And within less than 10 years, you could get HIV therapy in each and every clinic across the country in an integrated model, not a freestanding clinic, right? So a lot of what we try to do is say, let's help governments make a national plan. Let's put as much donor money into the national plan as we can, make this an integrated plan, not make this a parallel system. And this is just some primary healthcare reform that we did in Lesotho, showing that by just orienting primary care to address the burden of disease, we could also see increases in ART enrollment. We could see increases in vaccination. So now, what are we going to do? So I think for us, Global Health 3.0 is, what does this all look like without the United States? Because that money, at least for now, we'll keep fighting for it. But we also have to think about what that means. You know, it's $23 billion. And, you know, we're also thinking of the Global Fund, and I'm just going to go back to one slide that was somehow out of order. Here's a critique, right? A lot of donor money, USAID money, was very much parallel to the system, right? Went to a lot of trainings where people would drink tea and watch PowerPoint and not necessarily be on the front lines. USAID money cannot pay for public sector salaries. So it does support people through these per diems that create really